The contents of this film are for informational purposes only. Nothing contained in this film is intended to substitute for medical advice, diagnosis, or treatment. If you or someone under your care has healthcare related concerns or questions, please seek the advice of a physician or other qualified healthcare provider. In this series, we focus on Vietnam, although the principles are relevant to any trauma. Logos: U.S. Department of Veteran Affairs, Veterans Health Administration, Geriatric Research, Education, and Clinical Centers, Office of Rural Health. Title: Cognitive Impairment of PTSD, Veteran End of Life Care, Film 3 of 3. Camera slowly tilts down from ceiling. Text on screen: Les Bloom Residence, 6th visit. Camera continues to tilt down until Les Bloom appears, fear in his eyes.
Les.
Nurse Chad Brooks sits close, concerned.
Les, you're here in your home.
Les remains fearful.
I'm your nurse, Chad, and I'm here with you. Your wife is here, too.
Miss Bloom sits close.
I want you to look around.
Les's eyes remain locked on the ceiling.
Can you see the room? Your wife?
Les maintains gaze.
We're at your home, Les. The walls are white, your chair is brown, and I'm checking your blood pressure. You're safe. Les, my blood pressure monitor is still around your arm. May I remove it?
Chad removes monitor.
He's been doing that a lot since your last visit.
Does it seem to happen most when looking at the ceiling?
It's like he's afraid something's gonna fall on him. But then, sometimes he just stares into the distance. Like something's out there.
Chad thinks.
And the reaction, is it more like what happened 2 weeks ago or today?
It varies. But they're definitely more aggressive at night. I think that's why he wants to sleep separately.
Les, we noticed you seem uncomfortable when looking up at the ceiling or looking off into the distance. Can you tell us what's happening in that moment?
The air. When it touches me, I can smell him.
Chad looks around the room.
Would it help if we closed the window?
Chad motions for Miss Bloom to close the window. She stands, closes it, then sits down.
Les, we closed the window. Can you still smell it?
He's still there. I can't see it. He's still there.
Are you remembering something?
I can't get away.
Flashback of Les within a dark, narrow Viet Cong tunnel. He raises a pistol and flashlight, senses acute fear, controlled and direct. He glances down, searching for tripwires or trapdoors. He takes another step, but something or someone rustles above. He aims flashlight and pistol upwards. He listens. Then a subtle breeze alerts his senses. He moves flashlight and pistol down toward the depths of the tunnel, illuminating the path ahead. When a Viet Cong fighter appears, Les moves forward, but a tripwire yanks a grenade from an overhead tin can. Les turns and retreats as the grenade ignites. Flashback ends.
Are you remembering a time you were in danger?
Les, frightened, nods yes.
Are you remembering Vietnam?
Les's eyes divert from the ceiling. He stares straight ahead.
You survived, Les. You're safe at home with your wife. We'll do everything we can to make sure you feel safe.
Les continues his gaze.
Symptoms of post-traumatic stress disorder, or PTSD, may present differently in those with cognitive impairment. Such individuals are more at risk to become disoriented by sounds, smells, memories, and flashbacks. Some patients may be able to verbally communicate their experiences or fears, while others may rely on nonverbal communication, such as looking afraid, striking out, or trying to move away. Using techniques called grounding may aid in bringing the person back to the present. Change the environment, keep a nightlight on, play music, or draw attention to the here and now. For example, describing the room and how the person is physically connected, such as saying, "You were sitting in a soft chair." A person experiencing a flashback may have difficulty orienting themselves to present-day reality. Because of this, they may believe a person wants to harm them when in truth that person wishes to help them. It is sometimes hard to know what is causing behaviors. Knowing someone's trauma history can provide clues.
Can you tell me what job you had in Vietnam?
Les looks at Chad but doesn't answer.
Or Mrs. Bloom, can you?
He always said he was an engineer.
Les, were you an engineer in Vietnam? Would you like to share your job with us, Les?
Les's eyes begin to well up.
Tunnel rat.
Tunnel rat?
Les fights back tears.
Did you have experiences as a tunnel rat that bother you now?
Les nods yes.
Would you feel safe talking about how those experiences impacted you?
Les shakes his head no.
I understand. Would it be okay if I check in with you at another visit?
Les nods yes.
We can take it slow and figure out together how you can share so you feel in control and it's less upsetting.
Les nods yes.
Les, I wasn't able to get a good reading on your blood pressure. Would you like me to recheck that now or after I listen to your chest and breathing?
After.
Great.
Chad picks up stethoscope.
Can you sit up for me, please?
Chad puts diaphragm on Les's chest.
Perfect. If you start to feel uncomfortable, dizzy, or anything else, let me know. We can slow down, okay?
Explaining what you plan to do and offering simple choices remains central to providing trauma-informed person-centered care, especially for individuals with dementia. This can help a person gain a sense of control when confused or agitated, or when memories become overwhelming. Aggression, physical tension, and pain may also be present, but relating it to PTSD, medical illness, or a combination can be hard to determine. For example, difficulty sleeping can be a symptom of PTSD and can be worsened by nightmares, but is also common in other medical conditions. If you know the person's story involves military experience, then it may be helpful to consider its role in contributing to or worsening these symptoms.
Chad and Miss Bloom talk privately in kitchen.
As veterans age, many carry lasting effects of trauma, which can manifest in unique ways late in life. But if a person is unable to share information because they are feeling confused or they find it too difficult, we may need to find alternate methods of understanding them.
You think he has PTSD?
He seems to show those symptoms.
I knew there was more to it.
I've been having the same thoughts over the past couple visits. I started to notice he's been more impulsive, and his aggressive behaviors and withdrawal were worsening. Couple that with what seems to be flashbacks. Mrs. Bloom, I think it's time we discuss if there are other things we need to do to best care for your husband.
Alone, in the dark, knowing someone is waiting for you. And you still go in?
Your husband's a brave man, Mrs. Bloom.
Yes.
Family members may not be aware or are vaguely aware of traumatic events experienced by their loved ones. However, they may be conscious of potential triggers. For example, a loved one with cognitive impairment may get more agitated in a shower if it reminds them of a foxhole collapsing during a rainstorm. It can be helpful to ask family members when they notice heightened agitation or anxiety. Keep in mind, family members may feel more distress seeing their loved one in distress, but not knowing the underlying reason. Both patients and caregivers benefit from the support, reassurance, and education about how early traumatic experiences may re-emerge at the end of life. For a healthcare provider, understanding PTSD, how it may affect the dying process, and how it may present differently in patients with dementia will help you care for patients and their families at the end of life.
For more information, go to www.va.gov or www.ruralhealth.va.gov or www.va.gov/GRECC/. The Cognitive Impairment of PTSD film was funded by the U.S. Department of Veterans Affairs Office of Rural Health. Learn more at www.ruralhealth.va.gov. Credits roll.